Good evening, everyone. Thank you for joining us to celebrate the month where we think about brain tumors and patients that we care for that have brain tumors. My name is Isabelle Germano. I am a neurosurgeon at Mount Sinai, and I'm also the director of the brain tumor program. And tonight, we are fortunate to have a few members of the group. The group is a very important asset for patients with brain tumors because we believe that the care for brain tumors does not just come from one subspecialty or the other, but it really is comprehensive of each of us, and each of us is the leader of the group when the care that the person is responsible for delivering is necessary. So Dr. Kevin Elmore is a neuro-oncologist, and he will talk to you about what is really important for personalized medicine. Dr. Stas Lazarev is a radiation oncologist, and he will talk to you about what has been changed about radiation. And Kenisha Blake is a nurse practitioner with a tremendous amount of experience in both as a nurse practitioner and also as a brain tumor specialist. So we designed this seminar to be interactive, and we will do a little bit of a presentation, but we will also try to ask each other questions and then ultimately answer the questions that the audience has for us. Here I put all my titles, not because I want to impress you, but just because I want to show you once again that being part of a large group of doctors taking care of patients with brain tumor is really essential to deliver the best possible care. The other thing that I think is very important when assuming the position of leader is not just to be involved with your own institution, but also to be nationally involved. Because when you are nationally involved in the care of patients, then I think you can provide the best possible updates and also help this country moving forward and therefore enhancing the care of patients across the states. The first question that patients usually ask me when they come to my office and they receive the diagnosis of a brain tumor is this really a rare disease? And the answer is yes and no, right? So all we see, this group today on the webinar, are patients with brain tumors. So for us, they are not rare tumors. But if you look at it with a different lens, they're not that common. When we talk about primary brain tumors, those are tumors that grow and stay within the brain. It's approximately 24 over 100,000. And metastatic brain tumors, and those are tumors that come from a different organ and then go to the brain, are 5 times as common. So that number that you see on the slide, instead of being 24, would be 125 over 100,000. So they are common, right? And especially now that patients with cancer live longer, we see more patients with metastatic brain tumors. So how does my doctor know when is surgery necessary? If I go see the surgeon, am I really, the only answer I will get is yes, you need surgery. And the answer is no, you shouldn't, right? The surgeon will tell you that you need surgery only when and if that is necessary, and that is decided by looking at what we call evidence-based medicine. And we constructed guidelines, meaning the recommendation of whether or not surgery is necessary based on multiple papers that have been published over the years. And so when we look at this like a triangle, we have a variety of papers that really provide a little bit of evidence all the way at the bottom of this. And then when we go to the top, the red actually here, you see this evidence from controlled trials. And this is what we aim at. This is what we want to have so that then we can give the guidelines. So when we look at brain tumors, what are the guidelines? Well, I led one guidelines in 2022 for the progressive glioblastoma, and I participated in the glioblastoma de novo. These are two very common primary brain tumors. And this is just to show you, these are major, it's not just one paper, it's multiple papers that basically tell us the same thing. And what is the message? Is that when you have a primary brain tumor, it is usually a good idea to take out as much as possible. And we have a level 2 recommendation, which is really a powerful recommendation, saying that if you can take out as much as possible of that tumor, your overall outcome is going to be better. And that kind of makes sense with any other tumor in the body, with a caveat, right? And the caveat is that in the body, unfortunately, fortunately, if you have a tumor in the liver, if you take a little bit more of that tumor and the liver that surrounds it, it's okay, because there is enough liver to function and to provide you with good function. In the brain, those margins are not really possible. And so what we really think is necessary for brain tumors is to preserve function. And we have now shown, and when I use the word we, is collectively, all neurosurgeons in the US have shown that there is really a benefit in having as much as the tumor removed, but also in preserving that symptoms. And also is good to remove the tumor, because you could have less seizures, which is a very debilitating factor. And also, you could have some of your symptoms that you present with that are resolved. And so I will show you this a very short video here showing this patient with this large tumor. And when I click on the video, I'm not sure if you can hear what she's saying, but you could see that she has difficulty talking and she cannot move the hand. And this is right before the surgery. So she has really a hard time with her hand. And then we performed the surgery, and she's now 7 days after surgery in my office. And you see that she can speak much more fluently. And when you see the fingers, you see that the hand is also much stronger. So why did that happen? It did happen because her tumor was real, and you see the MRI showing that that tumor was resected. Her tumor was really not destroying the tissue. Now here you can see the brain at the time of surgery, and you can see some of the epileptiform discharges as well that resolved then after the resection of the tumor. But her tumor here was not destroying the fibers, it was pressing against those fibers. So by removing the tumor burden, we were able to ameliorate her symptoms. As you can see from this cartoon, that's not always the case, because it could be that there is infiltration and therefore not all the tumor can be removed, or that the fibers were destroyed by the tumor. And so even by removing the burden, the symptoms do not come back. So I could go on and speak for 4 hours about surgery, because I'm very passionate about it, as you could possibly, I just can probably say, I mean, tell. But at this point, I will say that surgery is indicated, not all the times, but at time. And that your provider should really discuss with you why is that surgery is indicated and what are all the other options, because clearly there are also cases where other alternatives besides surgery are a possibility. I wanted to actually ask Kenisha now a couple of questions. Kenisha, are you good to talk to us? Yes, okay. So you see, I would say all of our patients, right, before surgery, you've been doing so for so many years. What are some of the questions and or concerns that patient can have when they're faced with the statement that surgery might be the best option?
Sure. So along with wanting to know what the procedures, risk, and the benefits are with the surgery, they're also concerned about things like my hair. What's going to happen to my hair? Will it be shaved? And what will happen after? So we usually tell them, especially at surgery with Dr. Germano, there's no shaving of the hair. The incision is usually within the hairline and never on your face. And as the staples come out, the incision is hardly noticeable as it continues to heal. And then if there is no hair, we usually try to do the incision along the crease line to make it less noticeable. Other concerns that patients have are with the recovery timeline. What would I be able to do after surgery and still continue to do? So we also discuss if the tumor is in a crucial area of the brain, there may be some temporary impairments, and we set expectations for physical therapy and transfer to acute rehab that may be needed.
Thank you, Kenisha. So that's really important, I think, to kind of being able to discuss the concerns you saw in that picture that I showed you of the patient. She was 7 days after surgery. So as Kenisha said, the scar is really not visible after we remove the staples and or the sutures. And it is important to know that your deficits might get worse temporarily after the surgery. And if that is the case, sometimes, most of the times it's predictable, and we discuss that. And we already plan for physical therapy because it's a very important part of the recovery time. I wanted to share one more little thing with you, and that is for brain tumors, right? What you see is not always what you get. And here we see a beautiful dissection of the skull base. This is a very small tumor. It's called a vestibular schwannoma that can be easily seen, and with meticulous dissection can be removed from the nerve. But for other tumors like the glioblastoma or some of the gliomas or some of the metastatic tumors, that nice separation from the normal tissue is not possible. And so we do need guidance, right, to get to the tumor. And so this is something that I pioneered at Mount Sinai many years ago, and now is widely used across the US. And this is a picture of the brain. And if I told you that there is a brain tumor there, you would say, well, I cannot see it because I'm a patient. But that's not the case. The case is that, unfortunately, this tumor is invisible. You do not see the tumor. And so how do we go by finding it? We point a magic wand, what we call a magic wand, and we look on a computer screen, and the projection of this magic wand is projected on the patient's self-MRI. And so this projection will tell us that by following a natural path of the brain that is called the sulcus, then we can go and easily find that tumor and resect it. There are other times where instead we need even more guidance than that. And here is what we think it could possibly be the bottom of the resection cavity of a tumor. But how do we know that we really took it all out? Well, the only way to find out is to use what we call intraoperative fluorescence, and whatever of the tumor is not removed, it will show fluorescent. Here is a book that we published many years ago, and this was really starting, the big theme of we need intraoperative navigation, we need intraoperative guidance to better serve our patients and to take them out. And here is that fluorescence that I was mentioning you. So when we reach at the bottom of the cavity, if we still see this pink fluorescence, it means that there is still tumor there. And then we have other tools that we can use, like the ultrasound and other robotic things to help us with accomplishing that resection. And then we have other tools that we developed in the operating room, but we then brought and share with our colleagues in radiation oncology. And this is a nice segue to Dr. Lazarev and his team and his expertise. So this is a machine that, as I said, was developed in the operating room. And then the idea came about to apply it to deliver very careful radiation to both the brain and the spine. And that is known as radiosurgery. My patients are always asking me, why do we need a neurosurgeon and radiation oncologist to do this? And my answer is, probably is the same answer that you would get if when you board a big airplane flying from the US to another continent, you would ask one of the stewardess, why do we need two pilots? It's the same thing, right? So whenever things are complicated and or potentially dangerous, you're better off if there are two people involved. And in our case, it's more than two people because it is a whole team of physicists and nurses and physicians. And ultimately, with this instrument, we can deliver not just precise, but really patient-specific treatment by changing the way in which the radiation is delivered. So this is just to show that there is a continuum from one subspecialty to the other. Dr. Lazarev, if you don't mind, I'm going to ask you to say a few words about yourself and then take it from here.
Of course. Good afternoon, everyone. Thanks so much for attending the webinar, and thank you, Dr. Germano, for giving give us the introduction and kind of talk about the nuts and bolts of surgery and the treatment paradigms for primary brain tumors, metastatic brain tumors. So I'd like to briefly go over. Give me just 1 second. I'm opening up the. Okay, here it is. You can see my slides, right? Wonderful.
Yes, perfect.
Going over maybe. Spend 10-15 minutes talk about radiation component of the treatment for brain tumors. I titled it Radiotherapy for Brain Tumors 2.0 with what's changed and why it matters. Because there's a lot of stigma about radiation because in the past the technology that we used included larger radiation fields, meaning a lot of healthy parts of the brain and other important structures of the body received radiation. So nowadays, the radiation has become more focused, more targeted, with a better side effect profile. My disclosures, I'm employed at Mount Sinai Hospital, and I treat patients both with conventional radiation therapy at Mount Sinai Hospital, but I also treat patients with proton radiation in New York Proton Center. And I'll talk to you about that in a second. This is briefly where we are. Mount Sinai is right by Central Park in Upper East Side. And just about 10 minutes drive up north, you'll find the New York Proton Center, which is a state-of-the-art facility. And Mount Sinai Hospital is affiliated with the center, so we are treating patients there as well. I would say select patients that require the treatment. I like to start with a quote. The only constant in life has changed. And the reason I'm saying is that, to give you an example, technology changes, right? So some of you may remember this phone from the early 2000s, Nokia. It was one of my first phones. However, the technology changes. And today we have, I think last week, I'm an Android guy, not Apple. So Samsung Galaxy releases a new phone, and it's absolutely spectacular. A new fresh hope on cancer. And you can see here a patient covered in white sheet lying in a hospital treatment table. And there's this ginormous X-ray machine. In fact, this was the 30-ton Betatron radiation delivery machine. And at that time, it was known as the most advanced radiation technology to treat cancer. It was in Montefiore a few years ago. Similar technology was opened up. And this is the one of the 3 machines that we have here at Mount Sinai. It's called linear accelerator. It effectively can treat any cancer. It's non-invasive technology. And when we treat brain tumors, we have this face mask. We're going to talk about this in a second. So the technology has changed. And finally, about 5 years ago, news came out here in New York City, states that a world-class cancer center known as New York Proton Center opened up. At that time, a $300 million facility in New York Proton Center was launched in partnership with 3 institutions, Memorial Sloan Kettering, Montefiore, and Mount Sinai Hospital, and is known as the ultra-precise form of radiation that helps minimize damage to surrounding normal tissues in the patients with cancer. Now, the highlights of the radiation 2025, we have advanced technology. We have a better way to monitor the treatment delivery live, meaning while the radiation is ongoing, we can actually ensure that radiation is going where it's supposed to go. It prevents radiation to healthy parts of the body, the brain. We have smaller radiation fields, which means we deliver less radiation to healthy parts of the body, so it's more targeted. And we have improved planning software, meaning when we plan radiation treatment, we actually can calculate the exact dose that goes to healthy parts of the brain, the exact dose that goes to the tumor, so we can actually minimize the side effects. How does radiation kill cancer? I get this question a lot. Well, the big picture is that radiation actually causes a damage in the DNA of the cancer cells. And the healthy cells have the ability to recover, however, cancer cells do not. And there's a whole course of radiobiology that we study as radiation colleagues to understand how it happens. When we use radiation, we generally use external radiation, meaning it goes from a source from above the patient. The patient lies in the treatment table, and this machine rotates around the patient, and it delivers radiation over some time. For standard forms of radiation, it's about 5 to 10 minutes. For SRS, we're going to talk about this in a second, it's about 30 to 45 minutes. During radiation, the patient does not feel radiation, does not hear it, does not see it, does not transfer to other people. This is different forms of radiation. Photons, known as the conventional form of radiation, is the most common form of radiation that allows us to deliver radiation anywhere in the world. There are different forms of radiation. 2D and 3D are known as older technology. We rarely use them these days. And then there's a highly precise forms of radiation as IMRT, SRS, and SBRT. And then there are protons, so we're going to talk about them in a second. I'll skip the slides for the sake of time. And I wanted to talk about SRS, or SBRT, which is the form of a high-dose radiation delivered to a small area of the tumor, typically either in one session or 3 or 5. So SRS, known as a stereotactic radiosurgery, it's usually one treatment only to a small tumor, less than 3 centimeters. SBRT is 2 to 5 sessions of radiation to tumors that are no larger than 5 cm generally. This is just kind of a CAT scan of the brain, a slice through the CAT scan, and this is our radiation plan where this is the kind of a slice through the brain, through the middle of the brain. This is front, this is back, this is in medicine right, this is left, and over here on the top you have a tumor essentially that are receiving the full dose of the radiation that we intend to deliver, and the rest of the brain is getting a little to no dose of radiation. There's different forms of radiation for different tumors. Generally, if you have a primary brain tumor, meaning the tumor that's originated in the brain, whether it's glioblastoma, astrocytoma, meningioma, and so on and so forth, patients will receive a type of radiation known as IMRT or VMAT. That's generally delivered over the course of 5 to 6 weeks of treatment. Patients that have very small tumors, such as small meningiomas, acoustic schwannomas, or brain metastasis, we generally utilize SRS or SBRT, and that's usually delivered over the 1 to 3 or 5 treatments. And rarely we use 3D or 2D radiation today, where we deliver whole brain radiation for patients with many brain metastases. All right. A couple of words about proton radiation. Years ago, CNN asked this wonderful article asking, is proton therapy the magic bullet for cancer? Because it just kind of became the new thing. The basic idea behind radiation is that proton therapy is a form of external beam radiation that allows us to utilize the energy of heavy particles known as protons instead of X-rays, which you use for conventional fractionation. And this type of treatment allows us to spare healthy parts of the body a little bit better than with photons. It's been available in the States since 1990. It's not new technology, but there are only about 40 centers in the country and only about 100 in the world. Then the big picture for the brain tumors is that if the patient has a tumor in the brain, let's say over here, with regular radiation on the right, radiation beam goes to the brain, delivers some dose of radiation in front of the tumor, some dose behind the tumor, and so this dose may have an effect on patients. And then, with a proton radiation, we're actually able to confine our radiation dose just to the area of the tumor and protect the rest of the brain from unnecessary dose of the radiation. So in pediatric tumors, and I treat children as well as adults, this form of radiation plays a significant role because their brains are still growing, their bones are still growing, so we're able to minimize those to healthy parts of the brain. In adults, with very rare exceptions, We still use conventional form of radiation. It's highly safe and it's very effective. There are some tumors that require very high dose of radiation, in which case we would use proton radiation. Okay, so I'm going to skip through some of these slides here just for the sake of time. I like this question that one of my younger patients asked: if protons are so much better, why are we treating patients with photons? Well, the big answer is the cost of treatment. The regular radiation cost to the healthcare is about $20,000 to $30,000. With protons, it can be as high as $300,000 to $400,000 actually. And the final thing, critical care path. What usually happens with radiation, you see a patient in consultation, usually Dr. Germano or Dr. Elmore, who will be talking right after me, will refer a patient to me because the patient requires radiation. We'll see them, we discuss radiation. A few days later, we'll have them come in for the mapping session, it's known as simulation. Then myself and my colleagues will take care of treatment planning, and then a few days later, radiation will be started. So from the consultation time to the start time, it can be as long as 3 weeks, but sometimes we can get patients started within a week or so. This is immobilization device that we use to treat patient with brain tumors. It's a face mask. The patient needs to be able to lie flat and still follow commands. So there are some patients that are experiencing a significant amount of pain, or they're very agitated as a result of their tumor. So that requires us to get some help from our colleagues in other fields. And the radiation is delivered this way. Patient lies on the treatment table, and the machine delivers the radiation in a very precise fashion. The patient does not feel radiation, does not hear it, does not see it. And finally, I want to end on the side effects, because a lot of patients have a lot of questions about the side effects. I'd say the majority of patients will tolerate the treatment well, with exceptions of those that receive focal RT to certain parts of the brain. So this patient had radiation to the back of the brain, probably had a tumor in the back, and they will lose hair, not immediately. Hair will grow back, but there will be a hair, the patch of the hair is gone. Hair regrowth takes about 6 to 12 months. In fact, I just saw a patient right before I come in here whose hair is just growing back, and it's been now 30 months since finishing radiation. Some patients experience some skin irritation. We give them some lotions, darkening of the skin, mild headaches, mild nausea, fatigue. So most of the patients actually tolerate treatment remarkably well. It's the late side effects that we're concerned about. One is known as radionecrosis. It's essentially a medical term for extreme scarring in the brain, which may cause a malfunction in part of the brain where the radionecrosis happened. If radionecrosis happens in the part of the brain that controls seizures, it's a seizure center, so then the patient may develop seizures. Patients, this radionecrosis in the part of the brain that controls memory, patient may develop some mild memory deficits, and so on and so forth. Fortunately, this is a rare complication, but it does happen in about 10 to 20% of the patients, and we have ways to treat it, either with medications and rarely with surgery. Secondary tumor is a scary side effect, a late side effect of radiation. It happens on I usually quote rule of thumb 1 to 2% per decade of life. It's very rare, and I've seen it probably maybe 1 or 2 patients in my 10-year junior career. So, but it's exceedingly rare. Some patients may develop diminished hearing if the tumor is located close to the hearing centers of the brain. With very few exceptions, vision problems are exceedingly rare, but when they do happen, they can be quite significant. And we obviously involve the help of our neuro-ophthalmology and other colleagues to monitor for any possible vision issues. We do talk about memory changes, but I would say with very few exceptions, significant memory deficits as a result of focal modern forms of radiation is very rare. We do see some patients that develop hormonal imbalances, and I see that more in younger patients than my pediatric patients. Unfortunately, it can be managed with medications. So the bottom line is radiation is an essential treatment for a large variety of brain tumors. Radiation technology has evolved, improved significantly. Photon, or the standard form of radiation, remains a standard radiation technology, and protons can be used for select patients, mostly pediatric patients, some very young patients that require high dose of radiation, and in some cases of repeat radiation, we prefer to use proton therapy. And I will end with that, and I'll let Dr. Germano Thank you.
Dr. Lazarev, do you have any questions that you want to ask Kenisha?
I had a question that I meant to ask, and then let me just look it up exactly what there's quite a few questions I wanted to ask her. I guess the question had to do about I think about, sorry, just my about the timing. So the patient had a surgery, and let's say the patient is diagnosed with high-grade glioma, such as glioblastoma, astrocytoma. How soon after the surgery can they start radiation? What are the factors that we think about in terms of safety of starting radiation, in terms of wound healing, in terms of recovery, from the standpoint of neurologic function? You know, sometimes patients go to rehab, sometimes patients require prolonged hospitalization to heal from their surgery. So in terms of the timing between surgery and radiation, when do we get a green light from you guys from neurosurgery team to start treatment? What are the important?
Sure. So for in terms of the incision and incision healing, we tend to wait around 4 to 6 weeks for adequate wound healing because radiation can interfere with that. And we look for complications such as draining from the wound or superficial infections requiring antibiotics that may throw off the timing for the radiation. Each case is very different. So we take that into consideration. How fast is it growing? Was it a gross total resection or a partial resection or just a biopsy? So we take all of that into consideration. In regards to physical therapy and if they need to attend rehab, we tend to want to send the patients right away to rehab so they can get stronger, improve their physical function, which may lead to better outcomes after radiation. And also, the stronger you are and the more mobile you are, it allows you to be better equipped at handling the potential side effects of radiation.
Thank you, Kenisha. This is very helpful.
Okay, well, thank you. I think that another important aspect of brain tumors is to know that you are a unique patient, that although we do have standards, each person really requires their own special treatment. And so with that said, I think that we can continue on with our next speaker, Dr. Kevin Elmore. And perhaps, whoops, sorry, I wanted to show the, there we go, our little flyer one more time. And so, Dr. Elmore, perhaps you can say a couple of things about yourself and your expertise, and then tell us what is important for the care of each patient.
Absolutely. So thank you so much for the welcome. It's my privilege to speak to everyone today about empowering brain tumor patients. I'll start by echoing Dr. Germano and Dr. Lazarev's sentiments about how impactful advances in image-guided surgery and targeted radiation therapy have been for our patient group. And Kenisha's perspective on caring for brain tumor patients is also invaluable. I think it's so important to have a multidisciplinary team to have these different perspectives. I'll be speaking from the perspective of a neuro-oncologist and our role in selecting systemic therapy, including targeted therapy and clinical trial options. Here at Mount Sinai, I have additional roles as in education for anyone interested in brain tumors, any of our trainees, and then I direct the fellowship program. The neuro-oncologists, who are we? We're often responsible for organizing tumor surveillance, primarily through periodic imaging. We have the ability to prescribe chemotherapy and other oral and intravenous medications for treating brain tumors. We have expertise in the management of neurological symptoms such as headaches, seizures, and tumor-related swelling or edema. And lastly, all of us are involved in educating our patients on their conditions and advancing our understanding of brain tumors through research. This is an overview of how we try to understand the individual characteristics of each brain tumor as we practice individualized precision medicine. So primary brain tumors are classified based on microscopic appearance, grades 1 through 4, reflecting growth characteristics, where higher grade tumors are faster growing and more aggressive. We then use certain gene mutations to finalize the diagnosis, as well as predict behavior, including response to our treatments. So for example, IDH mutations is one of the most important. It's essential to the diagnosis of both oligodendroglioma and astrocytoma. For predicting tumor behavior, MGMT methylation predicts better response to alkylating chemotherapy, as well as better outcomes. Certain mutations are considered targetable mutations. Again, this includes IDH, but also BRAF, FGFR, and NTRK fusions. Tumors harboring these genetic abnormalities have specific treatment options termed targeted therapy. For many patients, having multiple treatment options can prove challenging as they try to navigate making the best treatment decision. And so our recommendations are tailored to each patient's case based on tumor characteristics, including size and location, as well as prior treatments. It starts with deciding whether surgery and radiation therapy are good options, or should medications be prioritized, including chemotherapy, targeted therapy, or immunotherapy. It's important to understand what the goals of treatments would be. So is this a treatment that could potentially help to live longer, slow growth, or improve symptoms? But to balance those potential benefits with potential side effects and the logistics of taking the medication. So is this an oral or an IV medication that would require coming into the clinic regularly? How often is it given? What monitoring is required? Discussing treatment preferences with your doctor can help to inform your neuro-oncologist as they tailor treatment recommendations to your specific preferences. And now looking at a few of these treatments. The most commonly used chemotherapy for glioma by far is the alkylating agent temozolomide. It was shown to extend life expectancy when used as part of initial therapy for glioblastoma. And this was around about 20 years ago now that this trial first came out. Temozolomide acts by adding an alkyl group to DNA, which damages its structure. See this here. Resulting in cancer death as these cells attempt to grow rapidly. MGMT is a protein normally present in cells, which acts to remove the alkyl group and counteract the effects of chemotherapy. So in tumors with MGMT methylation, less MGMT is formed. These tumors are more susceptible to temozolomide. Hence, why we might be more inclined to recommend additional alkylating therapy to patients with MGMT methylated tumors. Targeted therapy works differently. So this diagram shows IDH, one of those genes which can be mutated, and its normal role in generating energy for cells. When IDH becomes mutated in tumor cells, it causes them to accumulate the molecule 2-HG, and 2-HG results in downstream genetic abnormalities as well as cell growth. IDH inhibitors, like vorasidenib, are designed to prevent the mutant form of IDH from forming the byproduct 2-HG and avoid its downstream consequences. And so these drugs have been studied in patients with glioma. In patients with recurrent glioma, this class of drugs was shown to slow the rate of tumor growth. This is one of the figures from that study. You can see this is before the drug was started, that there was, this patient was experiencing some tumor growth, And then after initiating therapy, their tumor stopped growing and began to shrink. And here's a plot of the tumor volume showing the significant change in growth before and then after treatment was started. This study led to an additional clinical trial earlier in the disease course. So patients in this study had IDH mutant gliomas and were undergoing observation. So they were treated either with the IDH inhibitor vorasidenib or with placebo. IDH inhibition was shown to delay tumor growth, and patients needed chemotherapy and radiation at later times. Based on these results, vorasidenib received FDA approval for use in IDH mutant gliomas last August. Similarly, identifying gliomas with mutations in BRAF, FGFR, or NTRK fusions may expand treatment options. So targeted therapy in these patients are supported by basket trials. These are studies that look at various types of cancer that all have a specific mutation. And in each of these basket trials, there was a subset of glioma. So for example, the ROAR trial looked at different cancers with a BRAF V600E mutation. And these patients were treated with BRAF and MEK inhibitors, so two specific drugs that inhibit these molecules involved in cancer growth. Responses were seen in study participants across tumor types, including glioma. And so high-grade glioma, for example, had a 31% response rate. Response rate means the proportion of patients who experience a significant shrinkage in the tumor. And this was substantially higher than the historical response rate of temozolomide, which is about 5%. Next, we'll talk about how to navigate clinical trial options. So the National Comprehensive Cancer Network recommends clinical trial participation for eligible participants. While standard treatments are often an option throughout the disease course, clinical trial participation may allow patients to expand their treatment options beyond what is already proven. We study drugs when we have a reason to think that they might be better than available standard therapies. And so that's why when we have a good clinical trial option, that's usually our preferred treatment recommendation. It's important to recognize that these drugs are experimental. We're often still learning about side effects, especially in early phase trials. In later phase trials, we know more about the drug, and we're typically testing to see if it is effective. Available clinical trials vary by institution, and patients must meet specific criteria in order to be eligible. When weighing whether or not a clinical trial is right for you, you should consider the phase of the trial, what side effects have been identified during previous studies, and what participation would look like, since trials often involve frequent visits. And then, of course, you have to consider what those trial options are against what alternatives are being offered. So is there a standard option which makes more sense for your treatment preferences? I'll give you a couple of examples of clinical trials that are available at Mount Sinai. So continuing our theme of targeted therapy, there's a phase 1/2 trial in primary CNS lymphoma investigating targeted therapy with a drug called emavusertib. Emavusertib is an oral IRAK4 inhibitor. It's taken twice daily. Treatment with the BTK inhibitor, shown here, ibrutinib, is already known to be effective against lymphoma. It prevents activation of NF-kappa B, which is involved in cell growth. However, some patients develop growth after cancer cells figure out a way to grow through a neighboring pathway in IRAK4. And this trial is investigating the addition of emavusertib to block IRAK4 alongside ibrutinib, and so also blocking this neighboring pathway. Advances in trial design are underway to more efficiently test novel drug targets. And so this is an example from glioblastoma. This trial is called GBM Agile. It's a large multi-institutional platform trial, phase 2 through 3 that Mount Sinai participates in. So a platform trial, what that means is that patients are randomly assigned to one of several experimental treatments or a single control arm that uses standard treatment. This approach is better able to assign a higher proportion of patients to experimental therapies in later phase trials. So early planned assessments select only potentially effective drugs to continue on the study, and it's frequently updated to add new experimental arms while removing others. This is one example of a drug currently under investigation as part of GBM Agile. Arginine deprivation therapy with a weekly injection of Adipeg 20 is one of the experimental arms. This works because glioblastoma has trouble creating its own arginine supply, and arginine is necessary for cell growth. So Adipeg 20 works to lower arginine levels, causing cancer death and helping to restore normal immune function. And so I'll conclude just by saying that it's exciting to see building evidence that targeted therapy has activity in our brain tumor population, particularly the advancements with IDH inhibition and FDA approval of vorasidenib. So I'm eager to see how we continue to implement these treatment strategies as we learn more as a field. Thanks so much for your participation. Kenisha, I'll turn to you. So I'm curious, this topic of today's talk is empowered brain tumor patients. So one of the most common questions I receive from patients is, what can I do to improve my own health?
Okay.
How do you counsel patients to feel empowered in their own brain tumor care?
Sure. So, we do try to provide clear and understandable information for the patients. We encourage questions, participation in decision making, along with respecting their autonomy and their choices. We try to acknowledge their anxiety and feelings of uncertainty and encourage them to set goals, even if they're small goals. We also provide support or referrals, financial support, referral to social work. We encourage connection to different support groups and help them find or speak with patients if they request that have similar experiences and concerns. And I find that that does help ease some of the anxiety. We also encourage them to engage in activities that brings them joy. So they have a sense of self outside of their illness, like listening to music or other enjoyable interests that they may have. And just participating, I think, and including family if needed.
And Kenisha, I'm glad that you mentioned the word support groups. This seminar tonight is given in collaboration with the Almusella support group for patients. So Al, thank you. I know that you're part of the audience for partnering with us and over the years to help all the patients in the New York area and abroad to really get in touch with experts. Dr. Elmore, I think you were trying to get one more question in. I cut you off, so please go ahead.
I have one more. I can, so Kenisha, your team's in the unique position to often get to be the first to get to know our patients after a brain tumor diagnosis. And what aspects of quality of life are patients most concerned about when you're speaking to them about before they're starting systemic treatment?
Sure. So it's a combination of things. Physical well-being, their psychosocial, and also their social well-being. Physical, the side effects of systemic therapy, what they'll be able to do after or during exercise, and so forth. So psychosocial, more emotional, also anxiety, their cognitive impairments that may or may not occur. And then social also, if they're still able to maintain social connections, are they still able to see friends, visit friends? What type of support they have at home? Will they be able to work? And are there financial concerns? So a lot of those questions do come up.
Yeah, and I think those are all, yeah, things that we hear about as well. And one of the good news that most patients with gliomas who are going on to systemic therapy are oftentimes starting temozolomide as being the most common treatment. The good news about temozolomide is that it really, is not only what's been shown to work the best for tumors like glioblastoma, but it's also well tolerated. And so the list of side effects, that it does have some, but are generally pretty tolerated. Patients are usually surprised with their experience compared to what they might have been thinking about with chemotherapy. And so for patients, for example, you mentioned returning to work, patients who are eager to return to work, who are working before their diagnosis, oftentimes are able to do that, and even while they're on treatment.
Thank you. And we have a couple of questions from the audience. So the first one is for Dr. Lazarev. For an elderly patient, can you compress the radiation treatment to 1 or 2 weeks instead of 6 weeks for gliomas?
Absolutely. Yeah, so we always factor in, obviously, patient's age, patient's performance status. There are different elderly patients. There are patients elderly who are in their 80s and who are very active, who live independently, have no neurologic symptoms, neurologic function. For those, we generally tend to recommend the standard treatment that is known to provide probably the best outcomes in terms of the tumor control and survival. Now, for elderly patients who are experiencing trouble getting to the hospital, whose performance status is less than ideal, we certainly consider a shorter course of treatment. There's a 3-week course, there's a 2-week course. For some patients with glioblastoma that have significant neurologic impairment and for whom we think radiation is going to be beneficial, even 5 days of radiation can be considered. So yes.
Thank you, Stas. And I have 2 questions for me. One is, do all patients require a biopsy? And the other question is, what is the downtime after surgery? I think that Dr. Elmore started the topic about what to expect, right? So do all patients require a tissue diagnosis and a biopsy? And the answer is yes and no. So the answer is yes. The majority of patients does because of what Dr. Elmore explained, that there are so many targeted therapies here, that it's very important to know the signature of each tumor. And so if you have one signature as opposed to the other, there is a special drug that will be more beneficial to you. That being said, there are also situations where patients have a known metastatic cancer and the diagnosis of a brain tumor is done at the same time. We call those synchronous. That tissue diagnosis might not be necessary. And also there is the good news that there are more and more tools with artificial intelligence. We just published a big article on proteomics where with images coupled with artificial intelligence, we are starting to be able to identify some of those molecular signature. So I think that we're going to see less and less biopsies that are going to be needed, but for the time being, knowing exactly the signature of your tumor is in your best interest to be treated properly. The downtime after surgery, it depends on what kind of surgery one does have and depends where the tumor is located. It's possible to be discharged after brain tumor surgery 3 days or 4 days. That is the vast majority of patients that come in with a tumor that is not overwhelmingly big. There are tumors that are much more complex and or they already gave a deficit, and that deficit could worsen after surgery that require a little bit more of hospital stay. Kenisha and I try to really specify as much as possible what is the expectation, and that's why we ask questions such as, where do you live? Do you have to go up the stairs to go home? Do you live with somebody? Just to be sure that whenever the patient is ready to go, we have all that information and send them home safely. Okay, and the last question is for Dr. Elmore. if you have a treatment that works well, and if you have a trial, how would you choose to enter the trial as opposed to do the treatment that is already known to work?
Yeah, it's challenging because um, if we have a treatment that we know works and then there's a trial option, what order do we do them in, or is there a specific order that we would have to? So sometimes we might have a trial option that you can only receive a certain number of treatments before doing, and in that situation we might have another standard option in mind that it might make more sense to delay until later because it will still be there versus if we did the standard treatment first, then that trial could no longer be an option. That being said, if we know that there's a standard treatment that we think is going to work better and that's proven and established, most of the time a trial either wouldn't be an option or wouldn't make sense. You know, I think for when sometimes this comes up with glioblastoma, newly diagnosed glioblastoma, we're always trying to do better than what we have for glioblastoma, including with our temozolomide as being part of initial treatment. One way we think about it is those specific tumor characteristics, so MGMT methylated tumors that have that gene that predicts temozolomide might work better. That's one thing that would point us more towards standard treatment with temozolomide, and how quickly we can get it done is another. I think for somebody who desires experimental treatment in that situation, though, is also a good option. So if the patient wants to be on, is willing to tolerate some of the unknowns and some of the potential side effects, then that might be a good candidate for experimental treatment, as well as the frequency of visits.
Excellent. Well, thank you so much, everyone, for being with us tonight. Kevin, Stas, Kenisha, obviously this could have not happened without you. Taking care of patients is really a full team effort. So thank you so much. And thank you to our patients.
Thank you, Isabelle. Thanks, everyone. Thanks for organizing this. It's been great.
Thank you, guys.
Thank you, patients. Bye-bye.